15 minutes, we will go through the single step of dissection, and then we will have a break, and then we will start dissection around 10 o'clock. Now, just short again to repeat, we are used to the, now we go to the anatomy of the lateral hemisphere, so we will be very technical now. We are used to the lobar definition. These are the brain color according to purposed lobar anatomy. I think we all agree that there is a difficulty to recognize the boundary of single lobes of the brain, particularly if we consider the parietal-occipital transition. And indeed, it is like this, because even if you go to the oldest book of Dejerin, Minot, and all of the old anatomists, themselves had strong difficulties in finding boundaries. So you will find in every different book different boundaries for this kind of area. But again, it's a matter of perspective. If you look from a lobar perspective, indeed, it's difficult. But okay, if you look, and this will be the next step of our dissection, after the cortication of the brain, you realize very quickly that indeed the lobar definition, for our purpose as a surgeon, because you will have to operate here, 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 okay, so at that level, then the lobar definition indeed is not precise enough. So we need more. Another thing you will recognize that it is indeed difficult even to recognize, to orientate yourself in the brain anatomy. And why is this? Because the anatomy of every single brain of us is different. It is like the fingerprint, it is said. So the gyral anatomy, it's very, very variable among individuals. Still, we need, however, we cannot even say, okay, it's too variable, everybody does it so. No, we have to find a way to orientate ourselves, of course. And how do we do it? We do it by recognizing a pattern. Today, we will focus on the lateral pattern, and tomorrow we will go to the medial. On the lateral pattern, the most reliable reference are the sulci. The sulci, and also there, I repeat, and we will see later in the section, I will repeat it millions of times, the sulci also have highly variable. We distinguish between continuous sulci and interrupted sulci. The single fissure is a continuous sulcus. The precentral sulcus is almost always interrupted. We then have to recognize the sulci according to if they are continuous or not, and of course also if they are present or not, because not all of the sulci are always present. The sulci that are always present are the single fissure and the central sulcus. And these will be the first two that we will have to recognize during the section. We can then go to the second order sulci. Those are the sulci that are almost always present, but not always in the same manner, which will be precentral sulcus, inferior and superior frontal sulcus. And there we will recognize the precentral gyrus, the inferior. Sorry, right. So we will recognize the precentral gyrus, inferior frontal gyrus, middle frontal gyrus, which very often has a sulcus in between called sulcus medianus, and then the superior frontal gyrus. Posterior to the central sulcus, we will recognize the postcentral sulcus, which is bounded posteriorly by the postcentral sulcus, which is less continuous than the central is. Posterior to it, so-called parietal lobule, which has mostly two components. Very useful to define the limit of the parietal area is the postcentral sulcus and the Sylvian fissure. Because between these two, you will recognize the supramarginal gyrus, which arches around the posterior arm of the Sylvian fissure. Right? Lateral to the supramarginal gyrus, you have also here a rather inconstant sulcus, the so-called sulcus of Jensen, which divides the supramarginal gyrus to the angular gyrus, which would be, in this brain, would be this one. How do you recognize them? Supramarginal gyrus arches around the Sylvian fissure. Angular gyrus arches around the superior temporal sulcus. The two together, very variable. You will see everybody of you will have a different one. The two of them make the inferior parietal lobule. Superior limit of the inferior parietal lobule will be the intraparietal sulcus, which divides the two gyri I just mentioned from the superiorly located superior parietal lobe. Okay? We will repeat everything again during the dissection. Temporal lobe, two sulci, superior temporal sulcus, always present. Inferior temporal sulcus, always present, but almost always interrupted. So you will have to reconstruct it mentally. And the two sulci divides the so-called temporal lobe in superior, middle, and inferior temporal lobe. Posteriorly, occipital area, we will go in detail during the dissection because it's a very much more complex and variable area. Now, I have to change visualization mode. This is the steps we will do today. This is our brain. You will have, everybody of you will have its own hemisphere. And as Professor Carlo said, and allow myself to repeat, please go very slow, particularly at the beginning, because you're not confident with the technique, and you can really destroy everything in 10 minutes. So take your time. We have a lot of time. Compared to last year, we reduced the number of lectures to give much more time to dissection, so you will have plenty of time for it. So take your time to analyze your anatomy. Here we recognize our cilium fissure. We recognize our central sulcus here, rotating in every way to appreciate the anatomy. We'll see for the central gyrus, post-central gyrus, and all the gyri that we just mentioned. Second step will be the decortication. Decortication is the longest step of the whole course. It will be a couple of hours for all of you. Very, very gentle. Remove only the cortex by sparing the underlying so-called U fibers. U fibers are short association fiber connecting two adjacent gyri in a U manner. And they go deeply under the sulcus. You will see them slowly, by removing the cortex, you will see them appearing underneath the sulcus. We do it systematically. We make a so-called 2C system. We will start decorticating inferior frontal temporal sulcus. We will go backward to the Jensen and intraparietal sulcus, and then frontal superior sulcus will be the biggest C. And then we will make another smaller C, inferior frontal sulcus, over the central region, supramarginal gyrus, and superior temporal sulcus will be the smaller C. In the end, what you will obtain is this. All of the brain decorticated, apart, if you want, the most external part consisting of the superior frontal gyrus, central region, superior parietal operculus, occipital area, and then inferior temporal gyrus. Opercula must also be spared. Okay, so this will take 2 hours. Do it very slowly. We will help you. Also, the guys very experienced in dissection will help you in these steps. Second steps will be exposure of the so-called superior longitudinal fascicles. Now, what you will realize during dissection is following. At this scale, again, millimetric scale, you will not be able to see the single detailed termination of each tract. You will see an orientation of fiber system. And the superior longitudinal fascicle is exactly that. Are longitudinally oriented fibers going in the deep, actually, of the middle frontal gyrus, inferior parietal lobule, and middle temporal gyrus, connecting these areas. You will not find a single termination. Everybody of us will have a different fiber system, and this will be it. We will keep the opercula that we will remove at the end to expose finally the insula. And here we will take our time because the insula is a very important area for surgery. Again, we do transilvial insular glioma surgery, so we want to study. To do that, you need to study the anatomy of the insula very nicely. We will see this kind of triangular shape because the insula lies in the deep of the opercula, surrounded by the so-called peri-insular sulcus, which has 3 branches. We will see later, anterior, superior, and inferior branch of the peri-insular sulcus. We will recognize the insular anatomy, gyral anatomy, which consists of 5 gyri and 2 accessory gyri. The 5 main gyri are the short anterior insular gyri, and the long posterior insular gyri. They are divided by the so-called central insular sulcus. The central insular sulcus is a very nice landmark because if you see a MRI sagittally, you will see that it is continuous with the central sulcus of the telencephalon. So it's a good landmark to know. You will recognize again the 3 short insular gyri, the 2 long insular gyri. You will recognize the so-called transverse insular gyrus, which connects the insula to the orbitofrontal area. And you will then recognize limen insulae and apex, which is the most prominent part of this pyramidal-shaped anatomical structure. After removal of the cortex, what will appear? After removal of the cortex of the insula, we will recognize the so-called capsula extrema or extreme capsule. These are association fibers connecting the insular cortex with the operculum. So they have a very, very marked arching course around the peri-insular sulcus. This is a peculiarity which is very important to distinguish because those fibers that go to the opercula are the capsule extrema, whereas the fiber that go cranially to the remainder of the cortex, we will repeat everything later, don't worry, they are the part of the capsula externa or external capsule. Further step, removal of the first fiber of the extreme capsule will reveal, you see here, fibers going cranially, capsule externa, and here a gray matter, this one. This is the so-called claustrum. This is gray matter of the claustrum. The claustrum is interposed between capsula extrema and capsula externa, or extreme and external capsule. Next step, removal of the capsula extrema reveal the capsula externa, which has 2 components, cranial and caudal. Caudal part of the capsula externa or external capsule are 2 association fibers. The uncinate fascicles, let me just show it better to you. Here you see it better. Uncinate fascicles and inferior fronto-orbital fascicles. The 2 are the components of the caudal portion of the capsula externa or external capsule. Cranial portion of the capsula externa. And you see these fibers here, they do not go to the opercula, they do not arch around. They go underneath the SLA. And this is the landmark that allows you to distinguish between, again, extreme and external. In between, gray matter of the putamen. Removal of the caudal portion, putamen. We remove the putamen. We will expose the globus pallidus. And after removal of the globus pallidus, we will have the anterior commissure. Anterior commissure, which runs under the globus pallidus in the so-called graduale canal to connect both temporal lobes. And this will be the end of our lateral dissection, which will take all of today and maybe a bit of tomorrow morning. Again, I repeat, it's very important. We have a lot of time. We have 3 days of dissection full. So we had to do 1 half day. So you have the time, particularly for the first part, the decortication, take it gently and slowly, no hurry at all. Okay, so I think we can take the break until 10 o'clock. Then we go for the